Dr. Travers, he is a senior research scholar working in the area of exercise rehabilitation of musculoskeletal pain at the School of Physiotherapy at the University of Notre Dame in Fremantle, Western Australia. Murph's clinical background includes working with professional rugby union as well as providing clinical consultations for complex musculoskeletal conditions across sporting disciplines, but not only sporting disciplines, across a very large domain of people suffering from chronic pain. So over to you, Murph.
Thank you. Thank you, Thorvalder, and thanks to Tony. It was a lovely presentation. I think there'll be a lot of parallels between mine and yours, which is kind of really nice to see that, you know, I suppose if this was done 10 or 15 years ago, it wouldn't be such kind of transdisciplinary kind of care. So it's wonderful. So look, Valdi has said some very nice words about me, but of course it's very important that I acknowledge the people that I share ideas with, and more importantly, have shared their ideas with me. And so I have to acknowledge my colleagues at the University of Notre Dame, who I work closely on the topics that I'm going to speak about here. My colleagues at the University of South Australia, in Ireland, and here in Denmark, and also at Curtin University. So I suppose what I'm trying to say is I'm going to kind of present some very big, broad, and ambitious ideas at times. The ones you like, they're mine. The ones that you don't like, well, there's some other people you need to take that up with. Of course, you know, we learn so much, and I still see patients, and I'm involved in research kind of independently and in research supervision, and so much of what we kind of know, and so much of what I learn is through those interactions. So it's important that they're acknowledged also. Just before we start, anyone who's ever seen me present previously will know I always start with this quote, and it's one of my absolute favorites. It's ain't what you don't know that gets you into trouble. It's what you know for sure. It just ain't so. Does anyone out here who knows the very famous Oscar-winning movie that actually opens with this quote? Okay, one of my favorites, The Big Short, opens with this quote. Ironically, it's a movie about certainty and uncertainty, and how the housing market in America and other places collapsed because of our failure, our confidence in what we thought was certain that we didn't know, if you will. The great irony of this, of course, is that every time I've ever seen it, and including in the opening to that movie, it's attributed to Mark Twain, yet there is no evidence that Mark Twain ever wrote this. And so with that in mind, the reason I'm going to share some ideas with you, and I'm going to share some data with you, and you may well have heard different opinions, or you may interpret the data differently, or you may have had a different kind of clinical experience. And that's okay. You know, Tony does something different than what I do, and there'll be some parallels between what I have to say, and there may well be some differences. And I suppose we all come from a place of trying to actually do what's best for our patients, and kind of inform, you know, clinical care and healthcare systems usefully. So, you know, if there are, and when we're having questions, if there's things that you disagree with, let's actually discuss, because we kind of learn from doing that together. Okay, so with all those caveats out of the way, I suppose these are what the next kind of 40 minutes of our life looks like together. Firstly, I want to kind of answer the very simple question: does exercise work for chronic pain? If that's the case, how does it work for chronic pain? And then kind of set the stage for our need to take maybe a wider view of pain. And, you know, this applies to exercise as an intervention for pain, but also just our general understanding of pain and how that should direct our management. And then highlight some kind of emerging evidence, and you know, some future directions. And much like Tony's data, I think the last kind of 3 or 4 years has actually been transformative in terms of healthcare and in terms of care for people for pain. Because 10 years ago, I really felt like for people with persisting pain, we didn't have a lot of treatment options that had, you know, demonstrated, you know, positive outcomes, meaningful outcomes, sustained outcomes in well-done randomized controlled trials. They just didn't really exist. But there has been a wave of new studies and data come out in the last number of years, which I think offer great hope and should direct a lot of what we do. So we'll get there. Just one final caveat is that you know, pain and musculoskeletal pain is so broad, and just like Tony emphasized, you know, whiplash and kind of neck pain, I'm going to assume for the rest of this that I'm talking about low back pain, and within that you know, we're talking about low back pain where the kind of risk of serious structural pathology has been duly screened for. So if you will, that, you know, quote unquote non-specific low back pain. And so the question that needs to be asked is, does exercise work for pain? And I'm in this really privileged position where I get to fly around the world and work with clinicians of all kinds, helping understand and learn about pain, but also with patients. And that's wonderful. And one of the things I see constantly is clinicians who draw this like, direct line, this link between exercise equals good for pain. Excuse me. Unfortunately, the data doesn't really support that as well as we would like it to, I think. And so, for example, I've just pulled some of the better done large Cochrane reviews on various forms of exercise for chronic low back pain. For example, this Yamato one, it's about 10 years old now. They looked at Pilates and they compared Pilates to kind of doing nothing. And you'd really hope that your intervention would be better than doing nothing. And Pilates versus kind of other forms of therapeutic exercise, if you will. And so the first caveat before we kind of examine the forest plot is to remember that blinding is an issue in all of these studies. If you've been kind of randomized to the doing nothing group, you kind of know you've been randomized to the doing nothing group. And if you have a hint at all that, someone else has been randomized to the getting the whiz bang fancy treatment group, that may well reflect, bias is directional. And what I'm trying to say here is that the treatment effects that I'm going to demonstrate are likely inflated. Nonetheless, here, what we have is a treatment effect that is also inflated likely inflated because of imprecision that demonstrates that we're almost bordering on a treatment effect here that favors Pilates over doing nothing. It's almost at the cusp of a meaningful treatment effect. So Pilates is almost as good or almost better than doing nothing. And so that's, well, the lower end of the confidence intervals are below the kind of smallest or the clinically meaningful difference, and the upper end is a substantial difference. But we're kind of almost better than doing nothing. But it appears that if you compare Pilates to doing other forms of interventions or other forms of exercise, there's no difference. Then if we look at motor control exercise, which is another kind of form of therapeutic exercise for low back pain, you see a very similar scenario whereby compared to other exercises, the difference is, while statistically significant, falls well short of anything we would consider to be meaningful. So it's about 7 points on a 100-point scale. And when you get to 3 months duration, it's about 3 points on a 100-point scale, which is well below what we'd consider meaningful. So, Pilates is kind of maybe better than doing nothing, not better than any other form of exercise. Motor control exercise is not exceeding other exercise. And I can show you a host of individual trials and systematic reviews that show this. Probably the best done, or not probably, certainly the best done systematic review in this area was Jill Hayden's one that's 2 or 3 olds now. This is an immense body of work, an absolutely immense body of work. And I don't envy the authors in doing it because it was such a changing landscape. You almost can't keep up with the rate of publication doing this review. By the time you do it, another 50 studies have come out. So I can understand why I think they spent over a decade doing it. But they screened every single study and they set a 15 point out of 100 as being the kind of meaningful difference. And so if we look at what they actually found, now this is comparing exercise to kind of usual care. And in a lot of no treatments, because usual care in a lot of trials is go away and do the things you've done previously that haven't worked for you, which kind of translates to go away. And so what we found, or what they found, I should say, under these circumstances, with moderate kind of certainty of evidence, is just on the cusp. So just made it a meaningful difference on the lower end of meaningful difference for exercise. Now, they bundled all exercise together because no form of exercise is different than any other. So exercise is just better than doing nothing. And that's for pain, but it doesn't even hold for function. Then if we're to compare exercise to other forms of conservative treatment, and this could be manual therapy or any other things, exercise doesn't seem to outperform those other treatments. Interestingly, those other treatments are the ones that often get kind of labeled as passive, and that has this kind of inference that it's, in some ways a suboptimal treatment form. But exercise seems not to be the panacea for either pain or function for people with chronic low back pain, as kind of, I don't know, the healthcare industry would like for to be the case. And this is, you know, of course, I've had lots of patients I've given exercise to, and they've done better. And I remember those cases. That works 60% of the time. It works every time. But if we explore the data, that's not the story that holds up. Okay, one of the really nice things about the study I mentioned, bias, is that they actually went and they did a sensitivity analysis and they removed all the kind of spurious results and ones that looked like, you know, they could be issues with data integrity, et cetera, and the results still held. So they did the lie detector test and the results still held. So this is a very, very, very kind of strong body of evidence. And I suppose, you know, people will ask a question. Well, of course, you know, if I just get someone stronger, like if I make their back stronger, surely they'll be able to do more stuff and it will hurt less. Except we have no data in all to substantiate that, and the data we do have doesn't substantiate that. In part because the studies that say, I'm going to give this person strength training to do because strength is good and that's going to help their pain, don't actually measure the people's strength and track it over time to see if strength goes one way and pain goes the other way. Most of the studies don't do that. The ones that do don't find a relationship. And this has been shown not just in the back. So Miles Murphy, who's a tendon lord now, one of my former PhD students, we showed the same thing in the Achilles. It's not region specific, this phenomenon. And it's a challenge because as a clinician, you read these randomized controlled trials and they all open exactly the same. This will be a familiar statement to you. Low back pain is a problem. Lots of people get it. It costs lots of money, according to the Global Burden of Disease Index. It's a biopsychosocial phenomenon, meaning it's about more than just what's happening in the tissues. You go, okay, they've set this up beautifully. What are their aims and objectives? We want to investigate, insert form of exercise, whether it's effective for pain. And then you go to the methods section and go, well, what's the rationale? Why did they think exercise would be helpful? And when you read that, it's something completely tissue-based, which creates a dissonance from their statements above about it being biopsychosocial. All right. And so there is this disconnect. You know, we think exercise is helpful, intuitively want to think it's helpful, but the actual kind of rationale and therefore design of these studies doesn't match to a current understanding of exercise. And the data is not especially supportive of exercise as a treatment. And, you know, we have to think about our role in shaping the understanding of patients. So you've got, in some ways, Tony has in some ways made reference to these ideas of priors or people's implicit and explicit understanding of what's going on with their body and pain. You know, this data was only published last week, and they gave a bunch of patients with chronic low back pain, you know, pictures and videos of people doing 3 different exercises that are thought to be helpful by various groups for exercise, or for low back pain, should I say. But of course, one is a bird dog, which is basically like holding your core muscles together, if you will, and moving your arms and legs. One is doing a deadlift, and one was doing a Jefferson curl, which is basically flexing your spine under load. All right. And then they asked the patients, what do you think of those exercises? And of course, for where do you think patients got the idea that the one that's holding your core stable would be the most beneficial? And where do they think they got the idea that bending under load would be harmful? And so patients, you know, they say things like this: I could 100% see myself getting hurt if I did it wrong. And then we're thinking, but I was told deadlifts are good, exercise is good for back pain, and I don't understand why this patient doesn't want to do the deadlifts that I'm prescribing them. Can we see the kind of holes and gaps in kind of our knowledge and in clinical practice? And so, without completely dashing all our hopes and dreams of clinicians and kind of telling people to abandon exercise, I'm not saying that. What I'm saying is that no form of exercise seems to be better than another. And as Tony alluded to, there are other aspects that surround the therapeutic interaction that you can enhance in various different ways. It's just that the statement that exercise is good for pain doesn't really hold up. And so for me, if we're to use exercise, maybe I should abandon saying, I'm Merv and I'm a Pilates exercise, so you're going to get Pilates. Or I'm Merv and I'm a gym-based exercise, so you're going to go to the gym. Or I'm Merv and I like walking in the mountains, so we're going to walk your way out of pain. Maybe you should say, what do you like to do? And we can go from there. Now, the question is, you know, in some ways I wonder, and it's so funny, Tony, because your first question basically opened up with this: do we treat pain? And you know, this is a conversation I've had as recently as about 2 or 3 hours ago with a staff member here. You know, The question might not be how does exercise work for pain? Or sorry, the wrong question to ask is if exercise works, the question might be, well, how might it work? Do we understand that? What is the therapeutic target we're shooting for? Like, is it strengthening? And if it is strengthening, okay, then I'll target that. But I need to have a rationale as to why I think targeting strength would have a meaningful outcome of pain. There's a difference between a target and an outcome, okay? And so what's interesting is Leanne Woods, who's, I think she's finished her PhD now, is doing some wonderful work in this space. And she asked a load of different clinicians and researchers and patients, what is the target for exercise? And what's interesting is they came up with a list of 40 targets, which means exercise does everything, or we really don't know. And so with that, they prioritized 5 targets: improving function, improving quality of life, reducing pain, et cetera, et cetera. Now, I would argue that they're the outcomes we want. They're not the targets of our intervention, right? They're the downstream effects that we want, right? But like Tony has even said, it's, whether or not the person engages in value-based care, that's a target. Whether it changes their pain, perhaps that's an outcome if it's linked as a mechanism. And so if you look, as I said, at all the different randomized controlled trials, these are the different rationales and reasons of why they kind of have used exercise. So it's all about aerobic strength, motor control, flexibility. These are all things of the body, not necessarily of the psychosocial kind of components of this model. Again, this is another way of expressing the same data. So almost everything is grounded in tissue-based mechanisms. Look, having said that, if you look at work by people like Adrian Lau, Kathleen Sluka, Yo Nays, I mean, they are giants in our field. So I don't say this in any way to criticize them. The statements they make in their papers are correct. There are known mechanisms by which exercise can have a effect on people's pain. And known mechanisms by which it can have effect on pain behaviors of rats, for example. Like, there are kind of pathways, descending pathways for exercise-induced hypoalgesia, for example. Like, these phenomena, they exist. It's just we don't see that outcome manifest in randomized controlled trials. And so activation of endogenous inhibitory systems, reduction of central excitability, all these things, they're real phenomena. But what matters to me are the outcomes for my patients, right? And I have no way of measuring these things largely in my patients. And I suppose again, you'll all remember, anyone who did an undergrad physio degree will remember sitting down and learning the kind of neurobiology of pain. I'm tasked with teaching every year's crop of undergrad students at the university I am of all of this stuff, and I'm sure they in part loathe every moment of that time with me. But there aren't like known pathways from kind of higher centers in the brain to kind of rostral ventral medulla and periaqueductal gray matter down to your dorsal horn, where we can say, well, these are areas where we can try and target nociceptive trafficking in some way. So the argument is, if you affect nociception trafficking here or affect nociceptive trafficking here, you will influence people's pain. The problem is we don't see that manifest in clinical outcomes. And this is where I start to argue for taking a wider view of pain, getting away from very simplified schematics of how the nervous system works. That's a very, very hard thing to then. That's a very big leap to a person and their wider world. All right? Because what that person feels and experiences is a function of their nervous system, sure, but their endocrine system, their immune system, all of these nested systems within the physical body, but also, as we said, the social and cultural context, what they implicitly and explicitly know about themselves, their past experiences. And I'm not so sure all of that is dealt with by saying, I'm going to do exercise because exercise we have a short-term phenomenon called exercise-induced hypoalgesia. That's going to change that person's pain. So I'm going to argue that we should take a wider view. Okay. I think, and for many years, I've been really interested in other forms of conscious experience outside of pain. So what we see, what we hear, touch, taste. You had some bistable illusions that you've used to demonstrate predictive processing and mechanisms like that. I've been very, very interested in these things for a very long time. And I'm always interested in how we can modify what you see, what you hear. We can change what you see and what you hear and modulate it very easily. Well, why can't we take what we know from those fields and apply that to pain? And so what I want to do is just very briefly hold your hand through guiding you through this idea of active inference, which I think is kind of a kind of unifying framework for understanding what people's conscious experiences and attention and memory and learning. And so look, this is me. I'm a thing and I exist. There is a boundary that separates me from other things in the world. Everyone comfortable with that? Like, I am not this table. I am not the floor. Okay? So I am me, and external to me is the world. That world has stuff in it. The problem with the stuff in the world is my brain can never really directly contact that, right? So I am separated from things that happen outside of me. And equally, the world is separated in parts from me. And so what we're going to call all the stuff that happens outside of you, it's called the hidden states, right? Because it's hidden to you. You can never truly know what's happening outside of you because your brain just gets beeps and clicks and whistles and the odd chemical signal too. All right? And so that means inside of me, I need to have a kind of hypothesized generative model of what's actually going on in the world. And so what happens is something in the outside world impacts me, and it may well differ from my model of the world. And so there's surprise. And the thing about surprisal is we have a biological imperative to reduce surprisal. Think of a fish outside of water. That sounds like too much surprisal, and that will soon become dead fish. All right? So we have a biological imperative to reduce surprisal. And we do this in a couple of ways. One, you update your model. You update your hypothesis. You learn. Or two, you change the sensory information that's impacting your system. And this is really important. We do this through action. So I've got two sides of this equation. I can change my model, or I can change the sensory information. And what you experience is a function of your model and the sensory information. I'm going to give you some experiential examples of this in a moment. Now, of course, this is also happening inside of you. So often this is considered as an externally facing thing with exteroceptive. We will give you examples of vision and light and sound. And I'm going to do some in a moment because it's a good way of learning. But of course, this is also happening with the interoceptive information within your system. Okay. So this is my wife, Catherine. She's wonderful. And the thing is that Catherine can never experience the world exactly as I do. She cannot. Even if she's impacted by the exact same sensory information, her model has to be different than mine. Why? Because your model is made up of all your past experience, every experience you've had in your life, all the implicit knowledge you have, the things that you don't know, but you know, all of the explicit knowledge that you have about yourself, and the social cultural context, right? And I just don't see how they could possibly match for two different people. Okay? So that's active inference. Let's learn through experience. All right. What I want to do is I want to play for you a video of one of my favorite comedians, and I'm not his agent. All right. So I want to play a video of one of my favorite comedians, and I want to see if you get tricked. All right. So he's going to try and trick you here. He's going to alter what you hear. Now, of course, I just explained to you how active inference works, so you'll be immune to this. All right. Here we go.
You all know about a karaoke. When you're singing on a karaoke, you haven't got a clue that those were words. I was singing Take That, Back for Good. Wash your back, wash your back, wash your back. Want your back? What's this? Want your back? I've been singing Wash Your Back 15 years. So then when you go on a karaoke and you see lyrics, that's what they're supposed to be singing. You know that song, We Are Family? For years I thought they were singing, Just Let Me Staple the Vicar. Right? Who's right and who's wrong here? Listen.
All of the people around us, they say, can they be that close? Just let me state for the record.
That's what they sing. Just let me staple the vicar. What's all that about?
Just let me state for the record.
right. Who got done? Who got cut out? Did he get you? Yeah. Even though you knew that's not the real lyric. In fact, 2 minutes before, you just had an expert lecture on how active inference works. So you were extra immune. Nonetheless, did you get done? Yeah. Nonetheless, just let me staple the vicar is not a plausible lyric, but it's still what you hear. All right. Now, so what's happened? Well, you have your own model of what you're going to hear and what's going to happen. You're making predictions, not necessarily conscious predictions. Most predictions that are happening are implicit within your system. Okay. But he's informed your model by planting some lyrics. You already have some knowledge, some social cultural factors about our understanding of music and songs and comedy and how it all works. He's played for you sensory information, right? He's played auditory information has impacted your system. Okay. So you've got an auditory sensory stream. And an auditory sensory stream that doesn't match your model. So what have you done? You've minimized surprisal to confirm your hypothesis. To confirm the predictions of your system, you've minimized surprisal. How have you done that? You've done that by using your body. So anyone in the room, you able to tell me, what did you do? What information did you rely on? Vision. What did you use? What did you do?
Pronounce the word.
Yeah. So did you just listen with your eyes? I don't know. What you've done is you're faced with ambiguous sensory information he's planted quite a precise lyric for you. From the top down, you've precise information, but you're presented with imprecise information coming from your ears. And you've got to make a decision. Which am I going to side with? And then you use your eyes to confirm, because your eyes very precise information. He's mouthing the words. Yeah. And you confirm what you expect. You confirm what you expect. It's not a conscious thing. You didn't sit there thinking, I'm going to use my eyes to listen, but it happens. All right. And what this also says to me, and this is really important, people talk about pain being of the brain, and I don't think it is by any means. Pain and any other conscious experience is a function of the predictions in your system, most of which are unconscious, and incoming sensory information. And competition, precision-weighted competition between different sensory streams. All right, so now that you know that it works and you've had experience, all right, I'm highly confident he won't catch you out now. So have a listen and have a watch. Tony, don't be looking away. Use your eyes, please.
If you listen closely,
watch the screen, please.
About pork pie. Pork pie. Swear to God. Nothing's wrong.
Okay, to those who cheated and looked away from the screen, did you still get done? No? Why? You don't know why? What? Because you deprived yourself of the precise sensory information from your eyes. Okay? So you use your body to perceive. In fact, within the active inference world, what they say is that your motor system is enslaved by your sensory system. You only move in ways that confirm the predictions of your sensory system. All right. You had a strong prediction of the lyrics. You used your eyes to confirm that. All right. So the key point I want to make is this, that we actively create a percept that is shaped by our precision-weighted expectations, sometimes called priors, and sensory evidence. The point I want to make is using exercise as a mechanism to some way change nociceptive trafficking is not dealing with every aspect of this. All you're trying to do, that's grounded on, based on changing bottom-up sensory information. But maybe, and we actually know this, if you were to manipulate people's expectations around exercise, you may well actually, and its effect on pain, you may well influence both sides of this equation, right? You'd have a top-down effect. So, talking more about low back pain, one of the things that we see in low back pain is this very, very characteristic hypoesthesia and hyperalgesia. What do I mean by this? I remember reading these studies many, many years ago, and some of my friends and colleagues did them. And they'd say something like, well, people with knee-OA, they're cold hyperalgesic. That's really interesting. They don't like the cold, it makes them sore. I wonder if I was able to treat their cold hyperalgesia, don't ask me how, but if I was able to treat their cold hyperalgesia, would it affect their pain? Or is the cold hyperalgesia just a byproduct of being in sore for so long? Where does it sit on the causal pathway here, right? Or if we zap them with a laser, they say it hurts more than someone who doesn't have chronic elbow pain, for example. And so what we find with people with low back pain, you can move them more before they can detect being moved. You can press on them more before they can detect being pressed on. They can't detect shifts in their postural position. They are less capable of detecting non-noxious sensory information from their body, and particularly from the body part of interest, while simultaneously being much, much better at detecting noxious stimuli. So the people working here in labs who are zapping people with lasers and doing PPTs and QST and all that kind of stuff, you'll find this, right? They're much more sensitive to this. As there are some studies that conflict, but if you look at the whole body, that's what it seems like it looks like. So how do I interpret that? Well, let's go back here for people in pain. They have top-down predictions and understanding based on their past experience, the stuff they've been told, the time they were told they had the worst scan the doctor had ever seen. If they keep bending over, they're going to end up in a wheelchair. Your discs are degenerative. They have all of that. All of that. They carry all of that baggage with them. They're not always thinking about it consciously. Of course they're not. It's just part of who they are. We'll call those hidden predictions. Okay? All right? Hidden predictions within their system. They also have to deal with an influx of nociception, perhaps, because they may well have tissue damage. We might not be able to detect that with some of our clinical tests, but they may well have that. But equally, they have a sensory system that shines a spotlight on noxious sensory information. And if something's in the spotlight, then the non-noxious competing sensory information is in the dark. All right? What does all this mean? Well, based on this framework, a number of friends and colleagues of mine are responsible for what I think is actually the most important clinical trial that's been done as an intervention for low back pain, certainly in the last number of years, and I'm going to say almost ever. Okay, and I declare my bias because many of the people involved in it are friends and colleagues of mine. I wasn't part of it, not clever enough, but I'll tell you what they did. All right. They got a bunch of people with low back pain, the type of people who will very unlikely get better. I was part of the working group that just published the usual clinical course of people with persisting low back pain, and it is not a rosy picture, unfortunately. And they got a bunch of people like this. So whilst you had to have an average pain or a pain duration of 3 months to get into the study, it was actually, I think they were just shy of 5 years as the average duration of the patients. So they had pain for a long time. They had moderate pain levels, kind of 5 to 6 out of 10 was the average pain, and moderate disability levels. These are the types of patients who aren't going to get better, unfortunately. And one criticism of the study is that it was only done in a single center in Sydney. So, of course, you like things to be multi-centered and you like things to be replicated. So that's an acknowledgement here. But they got about 270 people, randomized into 2 groups. They gave them 12 treatment sessions over 18 weeks. The reason being, someone goes on holidays for 2 weeks, someone gets 6, misses a session. They wanted everyone to get 12 sessions in, done over 18 weeks, and they followed the primary outcome was pain at 18 weeks. They also measured disability and a number of other things, but they followed them up over the course of a year. But they had finished their therapy after 18 weeks. Now, here we go. This is the groundbreaking part, which at first will seem extraordinarily modest. There was a 1-point difference between groups. Success. That might seem very modest, but you have to interpret any effect size in light of the intervention and what it's compared to. And this is really important because we think about what's the difference, what's the smallest worthwhile effect for a particular intervention in a randomized controlled trial. And I'd argue they had a truly credible sham as their comparator. So hypothetically, what is the smallest worthwhile effect of a treatment that you think is real and everything about you thinks it's real and meaningful, and you have a realistic hope and expectation of getting better? It's an abstract concept. I don't think it's quantifiable. What this number is I would argue for the first time, signal above the noise, a true treatment effect of a non-drug, non-surgical treatment for chronic low back pain that shows a treatment effect above and beyond, placebo effects and Hawthorne effects and all of these other contextual factors that bundle in. This is signal above the noise. That's how I interpret it. But we need to have some context. So this is their results. These are their results demonstrated, if you will, temporarily. And so what you've got is this big drop in pain to 3 months and then sustained out. And if you look at the disability scores, there's about 10 people for whom it didn't work on, and yet the mean disability score in this group is like 2, meaning they made these people not disabled. But we need to understand why there's 10 people it didn't work on, right? Now, here we go. This is the intervention. It's called graded sensory motor retraining. And so it started with some pain education, right? Just trying to help reframe the person's understanding of the meaningfulness of pain in their body, etc. And then they trained them with graded sensory training. So remember, I said your motor system and your sensory system, and they work in tandem. So they said, okay, well, let's train your sensory system, the acuity of it. Let's train the acuity of your motor system, if you will, and then let's go to kind of graded precision feedback movement and exercise. All right. This was done over 12 weeks. And of course, you can see the shifting pattern of time devoted to each intervention. Now, if you were in the placebo arm or the control arm, if you will, what did they control for? They controlled for attention, time, love, and most importantly, your expectation that you will recover. Do not underestimate the expectation that someone will recover. Because isn't it item 7 of the Oswestry or gone blank that asks how much do you think you'll recover and seems to be associated with people's recovery. Okay, so they controlled for all those things. So the people got the same amount of time, but truly credible sham. So they had like a placebo pain education where it was kind of like Rogerian counseling, where you'd say, "Oh, my back is really sore." Well, why do you think your back is sore? I think that my discs are. Well, why do you think that matters? You know what I mean? So they kind of just reflected it back rather than saying these are your neurotransmitters or whatever else, right? They had a sham laser therapy, so like a laser, and it had all the beeps and beep, 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 and whistles and lights, but like it didn't do anything. Kind of like laser. And then they had a sham transcutaneal direct. So they had like basically think of it like a electrode swimming cap. We're gonna like do this to your brain. Why? Because they were told like this is a novel treatment that's going to treat the tissues and the brain, right? So they're getting treatments on all this. So it was very credible. And of course, they assessed that credibility, and the patients had no concept. You said, if you were in the control group, and we said, do you think you're getting the real treatment? Yep. And I think you're going to get better. Yep. If you were in the intervention group, think you're getting the real treatment? Yep. Think you're going to get better? Yeah. Right. So there was no difference between the two groups in terms of their kind of expectation of recovery. And so that's really meaningful and really significant for me, because no other studies have done that. There are other studies that demonstrate meaningful treatment effects compared to usual care or being on a wait list or A versus B, so a different kind of treatment. And they are not kind of uninformative. Like it's in no way saying that treatment or those studies don't have value. Of course they do. They just answer a different question. They ask a different question, they answer a different question. Here, what we're saying, we actually have a treatment that seems to have a signal above the noise when compared to a truly credible sham. That's a low cost, intervention that is related to movement, but using movement to understand and learn about the body, right? Because one of the things about reducing surprisal or self-evidencing is what it can be called. Think about if you give someone exercise and it's hurting them and they think it's going to break and they're going to end up in a wheelchair. What do you think they are self-evidencing, right? Versus someone who understands that they can recover and they've seen how they can their sensory system is operating a little bit differently and that can be retrained, etc. Layering it that way. What are they self-evidencing? And so when you look at the mediation analysis from that study, what is it that seemed to mediate their outcome? Was a change in their beliefs about pain and back pain, a change in their understanding of how they could use their body and their confidence to use their body even though they're in pain. So pain-related self-efficacy. All right. So that's what mediated their outcomes. So we have to think about exercise as a learning tool to learn about yourself, to learn about the body, all right, as a way to experiment to update a person's internal models of themselves. Okay, it's much, much less, to me at least, much, much less about the weight on the bar or how many reps they do, and much, much more about what they like doing, what they expect the effect will be, and fulfilling that expectation in some way, right? That's because that's how you learn. And you're using your body, you act to learn about yourself, and you're constantly self-evidencing your model, which is you. And so I argue this for exercise and any interventions that we want to apply, but particularly if we're talking about exercise to help people self-manage their pain, like we have to understand that a bit like this, if I order an iced coffee, right? In Australia, the cold milk, because it's hot there, right? Cold milk and coffee, right? Once they are put together, I can't separate them, right? When the cold milk and coffee mix together, they're inseparable. And your patient's pain is exactly the same. It's a function of their internal models and the sensory evidence. What we don't know is whether or not one person is 99% top-down influences and 1% bottom-up influences, or 50-50, or vice versa. And so it's funny because the single case experimental design is exactly how clinical practice should work. I think that clinical practice and prescription of exercise, and I had this conversation with Matthias today in the lab, exercise prescription for people in pain for me is an N=1 experiment. It's between two consenting adults, one of whom is a healthcare practitioner who hopefully has some experience and runs on the board, who understands the evidence, but has a guiding framework as to what they're trying to achieve. All right. And there's the patient who brings to the table their expectations, their previous history, their desires, their fears. What we're trying to do is experiment with something that induces, hopefully, some positive surprising. So as I say, this is what mediates the outcome. So maybe we've got to think about our exercise as can this exercise change their expectations? Can this exercise change positively their beliefs about the consequences of back pain? Can this exercise help them not ruminate over their pain too much? Can it make them maybe understand that maybe it's not so seriously damaged, for example, and that maybe there is hope for them to get better? Can they self-evidence and experience that? So with that, I'll leave you with the final slide is just how is this model operationalized? And so there's a wonderful paper called the Fitness for Purpose model, which is written by some of my friends and colleagues about that RCT. And we kind of think, okay, well, there is unquestionably a cognitive and behavioral component to pain because we're dealing with pain in humans, right? So we have to help the person understand that it's safe and helpful to move. What does that involve? That involves some form of education. I'd argue that it's not necessarily about a didactic lecture about pain mechanisms, right? It can be ideally through experiential learning pathways. You have to help the person feel that it's safe to move. And what I mean by feel, not necessarily feeling on the emotional level. We're talking about perception, how they perceive their body. Can we normalize and change how they perceive their body? Can that spotlight be shone on non-noxious sensory information from that body part rather than fixed on the noxious? Can they experience that it's safe to move? And that's where your movement experimentation comes in. And that's where really skilled exercise prescription is about finding something that may work and shift the dial for that person. And then they need to repeatedly explore themselves through movement and interaction with the world. That is called exercise prescription in the long term. That's your exercise programming as a mechanism to self-evidence and learn. In the words of Forrest Gump, that's all I have to say about that.